out of 4. I'm scaling it in 25% of the centers. Afterwards, we will see what effect this has. A country shows its commitment and progress about something happening when the program I'm designing is able to reach the majority of people. Second, it's necessary to improve access to care. And remember, we are specialists in saying that people have good access to care, but access to care in hearts, the way to measure it is through the number of persons that we are capable of identifying having this condition. If you have a TB program, then the first thing is to detect people with TB in order to provide treatment. If you have an HIV/AIDS program, the first thing is to detect people with this problem in order to be effective. If you have a mortality reduction and you don't know where pregnant women are, then it will be very difficult for you to have an effective program. So in hearts, like in any chronic disease, it's early detection that we need. And that is what we call access to care. The last point is to be effective in the treatment. In other words, improve the quality of care. So this is the tree, the policy tree that we need to have everywhere. So I invite us to have a first pause here for you to think about your own quality map. Think about your own quality policy in your country. Write it in the chat if you want. If you clearly understand the mission, there is a mission here for the Hearts program that has been identified as a priority for the country, and it has been identified as one of the priorities of the Ministry of Health, and the people participating in implementation understands clearly what they have to do, how far they have to get, and then look into each of these strategies and assess where you are located, your country. What is the point of inflection for you? And we're going to have an exercise in a minute that will be very interesting. And so far as we looked at the strategy, I ask you to self-evaluate yourselves. At the end of the strategy, you can have a first evaluation of what's happening in your respective countries.
So here you have the quality map. Now, the first task is for everybody to have this clearly reflected in the Hearts policy of their country. And you look at the general terms, then you go to the next section, which is much more concrete. Next slide. So the more concrete part that we're talking about starts with the strategy number 1. And I'm going to ask Andres to come up on the stage with me and talk about what effective governance is. What does this mean, Andres? Thank you, Pedro, and greeting to all the colleagues. It's a pleasure to see everyone and be in family. As Pedro was saying, the goal is to establish a governance mechanism that engages key stakeholders in the institutionalization of the model. In other words, not just have declaratory governance, but effective governance. And what does it mean to have effective governance? That the health authority, their government actions genuinely impact the structural resources and the processes that will lead to improving coverage rates, controlling blood pressure, and dropping the risk of high blood pressure. That's why the quality standard for this new vision, the evaluation framework for quality policy of hearts, will be based on the performance held via the clinical pathway across primary healthcare centers. It'll include validating blood pressure measurement devices, quality medications, and effective monitoring and evaluation system that promotes accountability and a continuous improvement of the quality of care. Well then, Andres, how will we know if we have effective governance? How are we going to measure effective governance? Well, all quality standards have to have objective, verifiable objectives, goals that allow us to value the gap we have in implementation. And as said, this indicator of effective governors will be built based on the performance each country has had in the 5 strategies that you see here on the screen. For instance, the guaranteeing availability of quality and effective medication to control blood pressure, accurate blood pressure measurement through training of staff and having clinically validated blood pressure gauges, have a standardized method for preventing blood pressure, high blood pressure, means you are scaling up the program, and you are can now analyze the information, collect information in order to be able to make decisions. Well, I learned this yesterday. I told my colleague that I was going to mention it today. So let me just throw it out. This quality standard, when we were looking at it through the former evaluation method we had, was very subjective. It was as if you were asking somebody, how do I look today? And I stand in front of the mirror like the which would look at the mirror and say, oh, Snow White, who's the most beautiful woman in the world? And of course, the Snow White would answer you. So we are living today in a society of mutual praise, mutual praising others. And so we need to put in an indicator that is really, really effective, because to make sure, we have to make sure what we're saying is actually done. Good governance, effective governance method makes sure things do take place and occur. So that's the first strategy, to have effective governance. The second strategy is related to accurate blood pressure measurement. Now, why don't you dot the I's on what accurate blood pressure measurement means? Well, Pedro, high blood pressure is one of the most prevalent risk factors. Some of the countries are 50% of the prevalence in adult population. So this is a real public health emergency. And as a result, we can't just guide our interventions on the basis of incorrect blood pressure measurements. That is a serious problem. And what we found so far is that most of the primary healthcare centers have equipment that are aneroid, that have not been calibrated, or they don't have enough, or they have automatic gauges that have not been clinically validated. That's why governance is expressed through ensuring that people have access to accurate blood pressure measurement by using automatically and clinically validated blood pressure measurement devices. So to achieve this strategy, the goal is that at least 80% of the blood pressure measurement devices available at primary healthcare centers that implement HEARTS have to be automatic and clinically validated blood pressure monitoring devices. We're also going to look at regulation, because this is an issue which for years we've been trying to convince countries to improve their regulatory structure, their framework, so as to ensure that devices that are sold in the country are exclusively devices that have been received a satisfactory clinical validation test. That's why the verifiable indicators for this strategy, number 2, will be, as in prior editions, the regulatory framework that ensures the sale and exclusive use of blood pressure measurement devices that have been clinically validated. Also, we need to find out what's going on at the health centers. We not only need a good regulatory framework and policies that provide access to these devices, but also we need to make sure that these devices are used effectively and at the primary healthcare centers as a priority, Well, here we could have a first conflict. People are going to say, well, where are we going to get the money to change our blood pressure gauges for more accurate ones? And we know it's a serious problem. That's why this is part of a strategy. But what we can't do is turn the face and ignore this and say, oh, this is not a problem. Either we put it on the map or we put it on the map. We have no other choice. And there are some places that are moving forward in this area. I'd like to call on Marcela Rivera. I saw her there a while ago. I'm here. I can hear you, but I don't see you. Marcela, are you there? Yeah. Yep, I'm here. Can you talk about what happened in Mexico when you established the regulation that states we are going to move to clinically validated manometers? Can you tell us what happened in your country? Well, 3 years ago, Marcela is the coordinator for primary healthcare in Chile, and she is the head of the primary healthcare center in Chile. No, I'm not the chief. I am a very humble member of a whole health team. Well, Marcela has focused on primary healthcare. Why is this so important, Marcela? Well, 3 years ago in Chile, with the health team that I'm working with on a coordinated fashion, we made a recommendation for use. We didn't make it mandatory at the time because the funding we had was very limited. And I'm assuming it's the same in all countries. But we said to our network, to take a person's blood pressure is important for everyone, but you have to use it with equipment where you're certain that the pressure taken is not over or underdiagnosed. So it's very important to have good equipment. So we listed the equipment available in Chile that had international validation. And in the Department of Non-Communicable Diseases, we have a subsecretariat that deals with this. We did a study and we demonstrated, and we published this in Pan American Health Magazine, that with that recommendation, by just suggesting that they use this equipment and not others, because this one was accurate, the purchasing profile in our country changed. Today, we can go into the field, and I've gone to accompany teams that say they're health centers that implement the HEARTS initiative. And we found that in most of them, 100% of the equipment gauges are validated gauges. We visited the centers, the places where they care for people. We talked to mayors. Our structure may be different from other countries, but in Chile, the municipalities are the smallest subunit of our organization, and they're governed by the mayors, and they're the ones that do the procurement. And their technical advisors told them they had to buy this validated equipment, and they accepted that suggestion. So the same money that they used for bad equipment, they're now using it to buy equipment that has clinical validation. Brilliant. Here we have to congratulate Chile and Marcela and her team, and Carolina Vera. Are you there also? She's represented by Natalia Bujaratini, and I'm not the chief. I'm part of the team. Pedro, one thing that Marcela was saying, with the same monies that they use for bad equipment, because there's a myth that this equipment is more expensive than those that is not validated, or the aneroid gauges. The fact is that we've been moving, and we've seen that providers have adapted by offering validated gauges at a lower price. We saw that happen in Argentina. The price of this equipment has been dropping. Can make another comment? In Chile, we have enforced the exclusive purchase of validated equipment because it had the experience of the law on bioequivalence and drugs. In Chile, there's a law that says that bioequivalent drugs, from the perspective of thermodynamics, pharmacokinetics, must meet the same standards as the original product. When that law came out, we thought that the price of drugs would go down, that the original price would go down, but the opposite happened. There was a copy of that product, but the price went up because it was validated by the Ministry of Health. It was just as good as the original, so the price went up. And most marketers said to us, if we give them a regulation that gives them a gold star, showing that they're better, those providers are going to raise the price. And today, the competition now regulates the market. So this is a lesson for other countries. With this recommendation, we have almost 100% of the centers that we visited only use validated equipment. Well, now we need all the VOCs to have the validated equipment, but all the primary healthcare centers have it. Thank you, Marcela. Good comment. What I did want to say, yesterday, the Pan American Health Magazine published an article from Peru. I won't mention it by name because it's a public article, but you can look it up in the magazine. Andres, could you put the link for people to read it? And I'll put it in the chat. And there was a team that evaluated the equipment that can be purchased in Peru. And it turns out that's why regulation is so important, Marcela. There has to be some sort of regulation because otherwise they can sell you anything. They can sell us a motorcycle in the drugstore if we're not paying attention. They sell it in colors, red, green, white, whatever kind of marketing they want to use. And we have to be very clear about what we need. So the first thing for there's something to be sold, you have a health registry. And if there is no registry, the other things can't be sold. Now, here in Peru, the gauges were under the list of equipment in Peru. And what they found was that 90% of the gauges on the registry, that is, that are authorized to be sold in the country, are not validated equipment, validated gauges. So the key to the door it is opened or closed by regulation. And if to be effective, you have to have regulation. And so Marcela, unless we have this, if we have this policy, the industry starts aligning because they see that if you have more providers, the only thing is prices can go down. And as far as I know, when there's big open tenders, public tenders, because we can't do individual procurement, but if you have big government list tenders, the prices go down. And I've used the countries of Mexico also. There is a strategy in Mexico called Let's Measure Blood Pressure with Accuracy. The third strategy is that we have to have effective medication to optimize treatment. These are not redundant words. It has to be effective and it has to optimize treatment. Go ahead, Andres. Yeah, we know that medication to drop blood pressure, there are many. In fact, we can lower it with captopril. But what's the problem? 25% of adverse effects. It had to be drunk 3 times a day. Nobody can keep such a treatment. Keep up taking captopril. So the goal of medication is to control blood pressure, and adherence to it and persistence with the treatment is crucial. Therefore we need safe medication, tolerable, accessible, that can be administered only once a day, and following the international guides, what the World Health Organization guides say, preferably combine different hypertensive drugs in one single pill, and also statins to prevent cardiovascular disease in a comprehensive manner, because CARTS is not a vertical program. It's a program where high blood pressure is the entry door to lowering cardiovascular risk. So the target here is to ensure access to a high blood pressure medication that are quality, that have an average lifespan that allows for medication only once a day, and in combination, in other words, a single pill, and also combined with statins as part of the primary health care. And there must be high potency statins to provide the proper treatment for patients who have established cardiovascular disease. That is secondary prevention. HEARTS is not a set of minimal recommendations for rural settings or for poor people, as we always say. What HEARTS seeks is to standardize the best practices and make these practices available to the entire population. Next. That's why Andres, I'm sorry. while you're speaking about this, I'd like to draw attention before we leave this point. I'd like to ask the Dominican Republic to get ready, and I'm going to have them speak after you. And I don't know who will be the spokesman for the Dominican Republic. So I want to use another country as an example. But Andres, go ahead. I saw Dominis there. Okay, on this strategy of effective medications to optimize, the indicators won't change significantly compared to the ones we were using. But we do want to have a national formulary that is updated and includes at least one combination of anti-hypertensive drugs in one single pill from the list of the WHO formulary. That continues to be a priority. Also, medications that are included in the clinical pathway must be guaranteed by the Ministry of Health, the Social Security, or whatever bodies responsible of providing the resources for the purposes of implementing HARTS. Because what's happened in some missions, we've seen a mismatch, a difference between what the clinical pathway recommends and the clinical pathway established by the Ministry of Health and the medications that a different office of the Ministry of Health provides to the primary healthcare center. So that short circuit means that we can't effectively implement the clinical pathway. Also, the availability of statins. Some years ago, when we started talking about this, there were very few countries had statins available for primary health care. Was medication reserved for specialized treatments. But we know that, as we always say, the target population that would benefit from statins is larger and larger, a larger group, and there's no specialist that can address all that situation. So we need to have statins available at primary health care.
Yes, and that's fantastic. You go to the centers where HARTS is implemented and you find medications in 30 combinations with statins. And before we'd been told that statins and some medications were only for use by hospitals and specialists, but now they're available. So the HARTS is a program for poor people, some say. But this makes sure is that poor people get the best treatment possible. And that's quite different than saying that this is a program, as we have heard before. It's very important then to be clear on this. There is an example, the Dominican Republic, to have a group of effective medications. And we have colleagues from the Dominican Republic. I saw Daniel also. So who is going to speak up for the Dominican Republic? Because they have done something fantastic. They have a list of medications available. They're available at primary health care, and they are giving free treatment and medications to people with hypertension and diabetes. Who will like to speak up on behalf of the Dominican Republic? Yes, Vanya. Go ahead, because you're an example, Vanya, of how things can be done. And the best thing is that one goes to the health center and the medications are there. One can see them. You've got the combined medications. So, and I'm not trying to promote any element. I have no conflict of interest here. But in the Dominican Republic, the treatment line is 40 and 80 milligrams of the Medicare. And this is the primary health care. We're talking about the primary health care. I don't recall if it was Subastatin or if it was Abastatin, but either one of us. So Vanya, please tell us. Thank you, Dr. Pedro. Yes, what has been done in the Dominican Republic in the past 2.5 to 3 years is this combination. It is interinstitutional in order to understand the magnitude and importance of having a strategy such as HARTS that is scientifically evidence-based and with simple clinical aspects direct to close the gap at the primary level. So we brought academia together with scientific associations that will be part of the HART strategy, from cardiovascular hypertension, diabetes, nutrition, endocrinology, obesity, and the family medicine. And these points were clearly and simply developed to ensure for the people in government to understand it clearly and understand that the clinical pathways or recommendations of such pathways entered a crucial moment of updating the basic medicine framework. That is a list that the country has saying that this has to be covered by both the public part and the social security. This makes it possible to change the medications, and as a result, this happens at the primary healthcare. The HEARTS pathway also made it possible for this to be the first list of medication launched with combinations. Through April of this year, the country did not have these in the basic table, but this scientific evidence showed that it was easier, more efficient, and cost-effective from the point of view of the ministry, of the service, and of Promes, who is the procurement and supplier of medications. So it's a matter of showing the benefits of the strategy, not only for caring of patients, but also because structurally and at the management level, this has to happen in order to achieve the right level. That's wonderful, Vanya. Andres, can you show the link of one of the papers developed under HEARTS of why the hypertension drugs are expensive, or why some countries are unable to buy the combined medications? Does this happen? It's not due to a market problem. It's a problem of health policy. Let me be very clear about this. There is a group, and Manya mentioned the list of essential. That's the first message that we send to people who prepare and the list of medicines and procure them. Strategy 4 now. Let's move on to that. It is precisely focused on that, Andres. And then with this, we're closing a trilogy here. We need to have the medicine and we need to institutionalize the clinical pathway. Without the gauge and without the medicines, we can't do it. So Andres, please go ahead. There are two things here. I've just put in the chat the article. You can download it. It's a PDF, and also the link to Stride VP, which is the most complete area where you can find all this Stride BP. So the country needs to establish a clinical pathway, approve it, and institutionalize it. HEARTS cannot be implemented without a clinical pathway, nor can you prepare a banquet if you don't have the recipe. You can have the ingredients and the best intentions, but if you don't know how to prepare it, the result won't be what's anticipated. So the clinical pathway reflects the best recommendations of the leading international guidelines, including those of WHO, and all this framework of action based on improving quality continuously is summarized on a single page. Most countries have a clinical pathway, therefore this is a tool that is very familiar to you all. However, the institutionalization implies taking it one step further. Each country will have its mechanism. Chile, for instance, was one of the first countries to move forward in an institutionalization mechanism through a ministerial resolution. Others have it in their policies or in their clinical guidelines. So this can vary from country to country. What is important is for the Ministry of Health, in the exercise of its authority, must provide to health centers the recommendations that are contained in the clinical pathway, and they need to guarantee resources for implementation. So the quality standard will be that more than 80% of PHCs implementing HEARTS have the recommended medications according to the clinical pathway, type, and dosage, including antihypertensive statins and aspirin. We're going to make some changes here compared to the earlier versions. Not only are we going to ask about the development and institutionalize of the clinical pathway, we're going to measure the quality using the appraisal checklist. But in addition, we're going to take a look at what's happening with the medicines. It is absolutely desirable that if the Ministry of Health wants to remain in charge of the heart's plan, they need to have data as to the availability of medications recommended by the clinical pathway, and these need to be available at the health centers. This is something we pointed out a moment ago. It's useless to have a clinical pathway if I don't have medication to support its use. Pedro. Okay, so we want to institutionalize a clinical pathway. That's strategy 4. Now let's look at strategy 5, how to do it. Optimize the quality of care. Esteban Ordoño, what does it mean to optimize the quality of care? Is there somebody available for this? There's somebody called Francisca. They seem to be drawing something on the screen, so if you could stop doing that, we'd appreciate it. Yes, sir. There's a practice with art here. Yes, but we don't really want it. It's best to leave the mouse and not touch it. Esteban, go ahead. Good morning to everyone, and it's nice to greet colleagues from all the countries, and thank you for being part of the Hearts family and sharing with us. So we're going to look at the structure, and we have 5 programmatic strategies for process. First, to optimize the quality of care. HEARTS, you might recall, is a program to improve primary health care. What does this mean? That we can only improve control of hypertension and reduction of mortality and mortality due to cardiovascular disease only if we improve the quality of the PHCs. Under this premise, we can say, well, but how can we then improve the quality of PHC? Our program proposes that through implementation of a series of interventions that we call the drivers, and there are 8 sets of drivers to improve primary health care. So this strategy means to empower primary health cares to implement the drivers. Our quality standard here, and there's a second question actually, but how do we do it? Well, by implementing drivers. Second is, how do we know that we're implementing the drivers correctly, and are they truly improving the quality of care to the population? The result is through an evaluation, and that is what you're well aware of now, which is the Hearts Maturity Index, which allows us to know what the level is for implementing the drivers and what corrective measures are necessary. The quality standard is that at least 80% of PHCs are implementing Hearts in the countries, and that they conduct at least one quality self-assessment every 6 months. This is an internal quality assessment. That is the standard. And this is complemented by the Ministry of Health or by any other subnational authority, that there be a complementary external evaluation, and then we'll have a very good practice to optimize the quality of results. Pedro asks Mexico to get ready now because Mexico is working on this. They have been extending the workshops for improvement, quality improvement. We saw this in Mérida, and when we reached Mérida, we saw that there are even further advanced than us. They have done their own evaluation, they're scaling up the model, and now the Hearts quality model is being adopted by the LINCS, which is a Social Security Institute, and it's being scaled up. So Vivian or whoever from Mexico, please get ready to talk about this. So Esteban, how are we going to measure it? Well, as you see, colleagues, we are going to emphasize the importance of quality self-evaluation. The centers have to do their own self-evaluation. Some colleagues in some countries We're going to publish the results of this soon, but if the health centers are very small, or those responsible for evaluation are somebody else, such as the polyclinicians or the health teams or what we call managers, that's good. You will define in each country, decide who has to do the evaluation of your PHC. You will have to decide who does the self-evaluation, but we will be assigning 3 points, scoring 3 points if this self-evaluation is done every 6 months. And there is something that has to do with external. This would be in charge either the subnational authority, the provinces, the municipalities, or the sectional, or the very ministry itself. So that is what I wanted to add, because this will be comprehensive. So Vivian, tell us about Mexico. What's happening there? Please go ahead. Hi, Pedro. I'm going to give the floor to Dr. Leah to talk about this. Very well. That's wonderful. Go ahead, Leah. Good morning. Based on the experience of our Merida workshop, we decided the workshop in that city with all the health centers, there are 13. And we worked with them so that each health center were to measure its maturity index. And well, we started with local data. Each center worked with their own data, I'm sorry, to establish a baseline of numbers and know what is the gap that had to be overcome. So using the maturity index for each center, and the quality committees has already been created within each health center. These committees had the director, the epidemiologist, the social worker, epidemiology, quality, because we have a quality manager, and we also included nurse and whoever is responsible for information or data. A platform was created. Each center uploaded their data. A improvement plan was developed for each center for a 3-month period. And based on using their baseline, they showed in which areas they were going to work. They were going to be able to move in their quality index. Simultaneously, we worked with the pharmacy and the filing section to establish the patient flow, so that once a person got to the unit, if they had high blood pressure, we wanted to make sure that there were no problems in access. And with pharmacy also, so that used on existing mechanisms for the delivery of medicines to people, make sure that the clinical pathway was complied with. If it is a person with cardiovascular risk, that the medications were prescribed to them. And we needed to see the average consumption or use so that they were able to procure the medicine in a timely manner. And now we are working with the Institute, and we'll start coordinating with the Social Security institution, because the Ministry of all of this has been now derived over to this new institution. It's impressive how you've achieved it. But there is something here that needs to be repeated by others. We're going to share this presentation with all of you, obviously, when we end the webinar. But what is it that we want to do? We want to strengthen the health center's capacity. It can be at the subnational, national level, but this has to come from the health center, because they are the ones who can manage things to achieve change. And that, I think, is the chief resource. In other words, strengthen the primary health care. And if where management is done, there is no data, well, then you can't share a program with them. It's as simple as that. It cannot be done without having a baseline and knowing what's happening. So it's very encouraging to know this is happening in Mexico. We know that there are more than 60 million users in that institute in Mexico. We heard this from Vivian a couple of days ago. It's 40-some million. The ordinary LINS has a coverage of 47% of the population. That's about 60 million. And the INS well-being is now going to take over the delivery of services and all the healthcare centers that were part of the Ministry of Health. And that includes some 12,000 establishments of the primary care and the rest of the population. Mexico has about 130 million inhabitants. But everything is interlinked. So let us see the strategies. You have seen that, and we're going to see the slide of how we evaluate indicators. Each country, try and see where you're at. You're going to have a preliminary status. It doesn't matter what it is. It doesn't have to be accurate right now. We just want you to start looking at the challenges you face. Through strategy 5, I need to say how much my country would accumulate. And don't forget what I mentioned earlier. We're not in a society of mutual praise, or mutual complacency. No, we're trying to see how to improve what we're doing. Because if we continue saying that we're doing everything wonderfully, but mortality increases, then either we're crazy or we don't know what we're doing, one or the other. And for that, it's necessary to do things in a different way and to be accountable. The government, the state, the country, the citizens of a country provide the resources, they pay taxes, they define their laws in order to have better health care. But then we need to create better care that is based on indicators. We need to be responsive, to be accountable about the effect that we're having with our health policy, and it shouldn't just be rhetoric. HEARTS is a multi-component program. It's a quality program. It is a quality to improve clinical performance. We need to have conditions when we look at this, to have validated gauges, effective levels, institutionalized clinical pathway. And above that, we say,
Optimize the quality of care. Optimize the quality of care. How can we say the poor? We can't say this is medicine for the poor to improve the quality of care for them. But actually, when we use those kinds of arguments, elitist arguments, the clinical the treatment is in the hands of the primary healthcare people who have great experience, and we don't do healthcare at the primary healthcare level, we're not going to be successful because they are the key to success. Pedro would like to say something very quickly. All of the health centers have validated equipment. We started with the donation given to us by PAHO, but Mexico also has a program of the government called the Clinic is Ours, Belongs to Us, where we give the budget to local health committees. So we meet with each of the local health committees. We introduce HEARTS to them. We explain it to them. We tell them the life expectancy is 64 years old, and cardiovascular disease is the main cause for death. And so we advise these communities, these local communities, and then they purchase the validated equipment. So right now, all the health centers have validated equipment. So you see, things can be done. That's excellent examples. Let's move on to the sixth strategy, the team-based care. What does this mean? Andres, Andres and Esteban, can you do a duo explaining number 6? We're going to have a Roomba duo here. Okay, so the team-based care has to be more than just a declaration of good intentions. From Almata, we've been saying that primary healthcare should be based on teamwork, but the doctor still continues to be the boss and master of all decisions. And in doing that, we're not going to get anywhere, because it's not that the doctors does things badly or doesn't have the intention of achieving goals far from the ideal, but it's because the magnitude of the problem is such that it can't be addressed unless we include other professionals of the healthcare team, others such as nurses, the pharmacists, even the community healthcare workers. These are quality drivers. Esteban, yes, I think we have to make one thing very clear. First of all, that we don't have enough doctors to cover the entire hypertensive population. We're in the world, we're 88 billion and 1.3 billion suffer from hypertension. At least 1 billion are in the lower and middle income countries. So no number of doctors is enough for that. But if to this we added that in our countries, low and medium income countries, it's a difficult to have an adequate number of doctors per se. We are dealing with a problem that occurs very frequently and doesn't always have to be treated by a doctor. Evidence shows that programs that work on the basis of teamwork, pharmacists, nurses, are much more effective programs. And then there's the case of Chile. Stop there, because that's a good point. I don't want to call it Chile twice, but I don't want people to think I have any preferences. But there's Carolina Neira. I saw her on the screen before, and I want her to get ready so that after Andres finishes, she can tell us about their standard. Carolina Neira, tell us how Chile is the first country in this region who has experience in training pharmacists to increase titering and using medication based on the clinical pathway. So, which is a standard we're proposing. Yes, we're proposing at least 50% of primary healthcare centers that are implementing HARTS, where nursing and pharmacy professionals, under supervision, of course, authorized by the regulatory entity, etc., and guided by clinical pathway, can intensify pharmacological treatment. Also, we should use community workers, technical assistants, health care agents to close the gap. As we saw, about 30% of hypertensive persons are not aware that they're hypertensive. So we could use this resource together with a clinically validated automatic system gauge and with proper training for blood pressure. If we do that, we can expand the diagnostic ability of the health center to reach out to more hypertensive patients and treat them. Okay, let's think on the following. If our health system, the way our health systems function, have been left behind, and we are proposing such as so basic as we're only happy if only half do this. All we're doing is saying a standard of 50%. We're saying we're satisfied with only having 50% of the centers. The nurses who are high quality professionals, and the pharmacists with training. Listen to what we're getting to when we have a program and we don't have appropriate quality control goal, where this is taking us. So how are we going to measure this so that Carolina Neira can now tell us how they reach this level in their country? Well, also, and this strategy, again, is based on evidence. Not only does it improve control rates, but it also decreases cardiovascular disease and mortality. So if we don't move ahead here, we are being accomplices to deaths and cardiovascular events that could have been avoided. Next. I still remember my trip to Rioja in Argentina in 2018, where they have a group of community workers that have been trained with equipment for measuring and screening high blood pressure patients. They do that in Argentina. And they took me to a very remote health center in a very economically vulnerable worker, and the healthcare workers were there doing this. So I mentioned this just so that you realize that these workers are making a difference. Okay, and how are we going to do this measurement? Well, let's continue now measuring the regulatory framework that allows nurses and pharmacists to provide treatment following the clinical pathway. We're also going to measure not only the ability that community health workers have to measure blood pressure, but we want to determine whether the countries are using this for a screening strategy. In other words, a community health care worker who has been certified through the course and has a validated blood pressure gauge, can they take blood pressure, and they can do so in a very valid way. And this can be considered the first blood pressure measurement, and then it is done secondly by a nurse to confirm the diagnosis and begin treatment, instead of doing what we're now doing, which is, in the best of cases, the community worker detects it's high blood pressure, sends them to a health center. The blood pressure is taken, it's still high, but they're told they have to have at least 2 visits, come back in 15 days. And when they come back in 15 days, they take the pressure again and it's high. These are all lost opportunities because half the patients won't come back. They have no time, particularly in vulnerable areas or the informal workers. They can't leave their jobs for us to take 3-4 visits weeks and weeks before we diagnose high blood pressure and provide treatment. So confirmation that this is happening must take place at the health centers. Andres, now, why don't you see how your country stands in this area? And let me, in the meantime, invite Caro Moreira. She's a nurse, high quality nurse. I think I can say this. She's the director for non-communicable diseases at the Ministry of Health in Chile. And they have prepared the first formula documents to allow the use of these drugs. Hello, good afternoon here to everyone. Well, we this year move forward to including pharmaceutical drugs with legal support to intensify treatment. In 2021, we added nurses as the legal support, but it was still in standby because we still need to have some changes in the pharmacy computer system to actually make the strategy operative. This year, we had the Secretary of Public Health, where people from their staff worked in the division responsible for pharmacies. We had Marcela Rivera from DIVAP and DIPRESE, which is us, public health. We brought together a bunch of the most important stakeholders to make a decision.
We achieved the legal support from the ministry, and what we're doing now is to put the strategy into operation and change the electronic score systems so as to generate a recipe with the non-medical professionals helping us. So that's the process. It's taken us over a year because the decision was made to not launch without having the legal support, not launch a strategy until we had the means to do it. We are going to start with a pilot in a health center. We have 29 of these large health centers, and we're going to gather and we'll see the barriers and obstacles in order to expand it countrywide. So hopefully next year it will be fully operational, both for nurses and for pharmaceutical clinicians. Yes, this is an intervention, says Pedro, one that is working the best in whatever environment it's being tested. This intervention de facto has the multiplying effect for the diagnosis and the treatment and improve control levels. So let me say that Chile deserves a round of applause because it's one of the first countries in the world that is at the forefront, not only for what we're doing in hearts and for cardiovascular disease, but it might be a model for other things. And actually, it's what we're doing. It's how we're doing it in many countries, or how we follow pregnant women, for instance. I recall, for instance, in Costa Rica, the primary health cares, and I don't recall what their name was, ATAR or something, they can go to the houses, look at the woman, the pregnant woman. So we are subusing a lot of all of this, and see how everything is interconnected. Andres, you recall statin and primary healthcare. No, statins can't be provided by healthcare, but we need to make it in an easy way. It cannot be put into primary healthcare. primary healthcare needs to have a certain specific medicine and not others. That used to be the heart's concept, but now we're saying that only the super specialists can manage it in the case of the hypertensive patients. But with the figures that we've heard for Esteban, we see that strides have been made. This is a quality standard. And when we spoke with the group, and when we were in touch with the countries, we said that this is a standard. We're at 50%, but things were so not working well that we needed to start with 50%. The gaps that we face, the resistance in many countries is extremely high. So let us move to the 7th strategy, having heard from Chile. Mariana Rodriguez, how do we move forward with training and certification? Well, as we've pointed out, this is a change of paradigm for care. We have always done this in one way, and as Esteban pointed out, it is impossible to manage to care for all the people who need such care with the existing and only with doctors. So we need to expand the working team. How do we do this? Well, by standardizing training to give people the skills to do this in the best way possible with the quality that Hearts proposes. So the quality standard here, as Leonardo pointed out, would be for more than 80%, ideally 100, but ideally 80% of all the team working in Hearts health centers be trained and having taken the standard courses. At present, all we're seeking or suggesting is that it be for the automatic and accurate blood pressure measurement. Everybody in a Hearts team have to have this skill. How can we achieve this? Well, through mechanisms and incentives to guarantee the standardized training. How will we measure it? The change here is to add a direct measurement of the health centers to know what percentage of the staff has been trained, and the other two would be to see what incentives and mechanisms are being used by countries. And this had already been, they had been evaluated in earlier versions. Well, that's wonderful, Mariana. Thank you. There are 2 countries that I want to talk about. The resources are there, the programs are there, the virtual course programs are high quality programs that need to be seen. They are evidence-based. There are professors. They have high level faculty. The content is updated. The content teaches people. They are self-administered. They are also free. So why don't the countries have a policy to have more participants of these courses, people taking these courses? And this ties into what we mentioned earlier about the clinical pathway for hearts. We're not saying that pharmacists to be trained or nurses if they don't have the necessary skills. We're saying do train them so that we can achieve this. There are 2 countries that have taken this to a higher level. One is Ecuador. Is Ecuador present today? Ecuador have truly been champions in this field. And Ecuador has said that to work in primary healthcare and to be working in hearts, people need to be trained and they need to have a certificate. The Dominican Republic has taken this to a higher level. They say that the course has to be provided at the college or university level. So the graduates for primary healthcare, they are actually the ones that are recent graduates. This is now part of the academic curriculum of the School of Medicine, or at least the science of health sciences, so that people are properly trained. Is Ecuador present? Teresa? No, Teresa Almada is not here. Otherwise, she would have raised her hand. She's the new undersecretary for health in Ecuador. One of her commitments is to implement Hearts. Is there anybody available from Ecuador? Are they present? Unfortunately, apparently not. But Vanya Otomidi, can you tell us what was done to provide HEARTS courses to include it in the curriculum of faculties of medicine and health sciences? Yes, everything is interinstitutional, as I pointed out. One particularity of the country is that in an institutionalized way, there is the Dominican Association of Schools and Faculties of Medicine, and availing ourselves of that association that encompasses the 11 universities in the country that have a school of medicine. And furthermore, some of these schools and universities also have nursing, psychology, and other careers. We were able to provide technical support to bring together the ministry with the ADOFEM in order to reach this agreement that has now been signed by the minister and the president of the association, so as to have it included in the curriculum. The same or something similar was done with the nursing schools. It's not exactly an signed agreement, but at least we have had direct contact and training for the nursing department of the Ministry of Higher Education and the directors of nursing schools and all the directors of nursing auxiliary schools at the universities. Lastly, as you pointed out, some countries have the intern, that is a recently graduated doctor that has to deliver to the country a year of service in order to obtain their license. And in the regulations for the intern, this has been included. So in the last year of internship, they have to show that they've taken the HEARTS course. That's an example, Vanya. And this shows the creativity of a country, how to use a top-notch resource for a country to do things correctly. And this is extremely important. I see Mexico has raised their hand. Yes, Mexico, please take the floor. Yes, we had our breakfast today. We're learning. And we also, given the interest of the authorities at the Ministry of Health as well as Social Security, we wanted to know who among their personnel had taken the HEARTS course, because it is established as a country, as PAHO, as well as in coordination. So what we did was clone access to these courses that were being provided regionally, but put it in the node for Mexico so as to add new variables and components, allowing the authorities to better identify who in their team and staff had taken the courses. This is a strategy that we were able to implement. We're getting good results from it because they are asking the PAHO office to provide a monthly database so that they know which of their staff has actually taken the HEARTS training. That's wonderful. Please put information in the chat. Describe your experience. We see that in Salvador, they have already trained the professors of 4 universities in the country about the HEARTS program. Let us now move to strategy 8. This is to have a functional monitoring and evaluation system. Angelo, what does this mean? Translate it for us. Pedro, this is just a matter of understanding that data is relevant to trigger the HEARTS program. And principally, the spirit of this strategy is for this information to not only be generated by the health centers, but even more importantly, to be used by them, because that way they can understand the gaps, which groups they need to focus on. They can identify needed resources. They can identify parameters or how much support is required from the central body. So it's important to have standardized data. Thank you, Angelo. El Salvador, please get ready, because after you tell us how to explain this, we want to hear from El Salvador. They are the Olympic champions of having data and a functional system for the center to do what is needed. So Matias and a colleague, we want you to tell us how El Salvador has been doing this, but we'll first listen to Angelo. What we're planning right now is to have a summarized system that is less of a burden for the countries and for the health centers. As you see on the left, there were more questions that had to do with plans and teams. But now what we want to do is have something more summarized, just measure the number of centers implementing HEARTS, and of that group, how many are reporting. So you can see the scoring here. The idea is to always use the DHIS2. This is the system we developed for you, but you can use any equivalent system. There are many examples in the region, but we want to have your participation. Yes, the DHIS2 is something that we discussed yesterday when preparing for this meeting. We were saying that this system is not a parallel system. It is not a clinical reporting. No, it is simply a dashboard where the health center can have data. And this is the heart's aspiration. We want to have a dashboard at the center so that the director of the center can take a look at it and say, I have so many patients, so many receiving treatment, so many are under control, so many are taking their medication. That's the kind of information and data we want. Matias and Nora, let me invite you to take the floor. Tell us how El Salvador is doing this. You have the floor. Good morning. A pleasure to greet you. Let me talk about the strategic aspect, and Nora will then focus on the operational aspect. So first, I'd like to thank you for this opportunity. We appreciate your recommendation, but we know without data, there's no program. On that basis, we addressed our Ministry of Health to focus on digital data, because this we realized was very important in order to implement HEARTS. So what did we do? We designed a clinical history for non-communicable disease, the cardiometabolic ones, and this includes high blood pressure. And in this clinical history, we included all the variables measured by HEARTS. Then we generated this clinical history. We asked a report sheet with all the HEARTS variables. And we uploaded the information on an Excel spreadsheet, and then we upload it to DHIS2. The good news today is that our program, our system can interoperate with the DHIS2. So the information is uploaded automatically from the health centers themselves. All of the health centers have their dashboards to evaluate how many trained resources they have. And with all those indicators you've mentioned, we have that real-time information, and it is consolidated at the national level for us. This is at 100% of the health centers that access networks. And there's a 1% of health centers that perhaps don't have such access. But that 1%, what they do is upload the information manually. But they're very small health centers, and their burden is very, very low, practically insignificant. Matthias, you took me to one of those centers in a remote area, and there we saw that they had their own dashboard, that the directors of that health center could see how many patients they had, when they were coming in for a consultation, what kind of medication they were having. When you took me there, you showed me how at the health center, after the patient comes in, they also verify the vaccination levels. So what Let us forget now about the strategy and the directives of the health ministry. What does it mean actually for a health center to implement HARTS? Well, first of all, it's a motivation for them, says Matthias. And now evaluating their results. Now we have 80 and 80, and we needed to reduce mortality. And the staff is well motivated because they're seeing the results of their interventions right now. And at that health center where we took you, at the next International Congress on Research, we'll be showing the result of HARTS implementation at that center because they had a 20% increase of control of hypertension in high-risk patients or even low-risk patients for cardiovascular disease, and also results in terms of mortality. And this is useful for decision-making. And it's important here to see that a program that is not assessed or followed up, then you can't see the results. Matthias, this sounds ideal. I'm sure other countries are looking at what you did. But tell us what you gained from having a system. And Nora, you tell us about this. I know that you made a tremendous effort. You were behind all of this to ensure that HARTS could be implemented in your country. Please go ahead, Nora. Thank you. Good morning. Here in El Salvador, we want to implement the HART strategy. Well, at the beginning, as you know, this was a process taken step by step because we had to implement it in some of the networks. Although we began in 5 networks in the country, by the next year, by the following year, well, first we evaluated to what level they had managed to implement it with the DHIS2 platform, and we were seeing the results. And the same year, the second phase was implemented with 5 other centers. And by 2023, the countries with support from the authorities implemented in 100% of the health centers. And we have about 728 health centers in the country. And Dr. Villatoro mentioned, and only 10 establishments do not have the system right now. And that just accounts for 1% of the centers. With the training, 100% of health centers were trained. We have 5 health regions. In each, there's a benchmark. And in each region, there are departments that receive the training, and they are now responsible for follow-up, for digitalization, and for use of the platform. We're doing feedback with physicians right now and with the health teams, so that with this process implemented by PAHO, and we're going to see the quality implementation of the systems. So we are providing feedback to interpret the drivers and how to obtain results so that they can improve it and can have better information through data interpretation on the platform. Doctors will see the results, but they need to know where each result is obtained. Everything that's on the platform, where did that come from? So that's a challenge that we're facing presently in order to control the quality of the information on the platform.
Wonderful, Nora. Congratulations, El Salvador. Very encouraging. I hope the neighboring countries, I won't give their name, but I hope the neighboring countries in Central America feel very proud to have a champion in Central America moving forward at the speed with which El Salvador is moving. I know progress has been made in Panama as well, significant progress. We hope that the progress in Costa Rica will be greater this year, 2025, because I know they're doing a lot of things there to get things to happen. So we are moving forward in this area. So let's move on to the 9th strategy. The 9th strategy is the one that deals with the results. The 9th strategy is the first result strategy, and it's called Scaling HARTS across the entire PHC service network. Esteban? let me begin with, in our region, we still have a significant problem, which we call the diagnostic gap. There's still a lot of people who don't know they have high blood pressure, they have cardiovascular risk. And as we know, the problem of cardiovascular mortality is a huge problem, very significant. So we are inviting people to look at this with urgency. We're not going to have coverage or control results unless we scale up hearts to the entire network of primary health care, to all the centers there. We want hearts to become the standard model for hypertension care and for comprehensive care for all cardiovascular risks. About 30% of the countries that are currently implementing hearts, only 8 have attained 80% scaling up of throughout their entire primary healthcare network. So as you see, we still have a lot to do. So the message for everyone is we have to have a sense of urgency. We can't just settle with what we have. We have to move forward and implement this throughout the network. Our standard in this field is that we want more than 80% of eligible health centers effectively implement the HEARTS model. And we want to have a scaling plan through 2026 that is aligned with the National Health Strategy. That's very important for implementation to be effective. But then let me ask Yamilien in Cuba to get ready, because Cuba is one of the 8 countries that has exceeded 80% of the scaling up. So I'd love to see a country in the Caribbean to volunteer. I don't see anyone right now, but I'd like a Caribbean country to tell us what they're doing, because El Salvador is a relatively small country. There's countries that are even smaller than El Salvador. And yet El Salvador is one of the ones that is implementing HEARTS in more than 80% of its health facilities. So, Esteban, the message you gave is key. If this is what we're doing in HEARTS is high quality intervention based on evidence and what we can do to change the way cardiometabolic disease is being treated and handled. And if we don't do this, it means what you said. We are not providing, using the best evidence, we're not providing the best program to most of the primary healthcare centers in the country. So what can we do to get things to change? Well, to reinforce this, as you said at the very beginning, if let's say my country's small and I only have 8 centers, primary healthcare centers, and I only implemented in 2, that means I am denying 75% the right to follow the highest standard. If in a big country, I have 8,000, I only implement it in 2,000, I am denying this to 75%. So if you see it from the perspective of rights, our appeal is please implement rights as broadly as possible. Try to extend it to all centers. Esteban, next one. How do we evaluate it? Go ahead. So here we're going to measure in all the health centers that have planned implementing HEARTS in the country, how many are actually implementing it. And so here we're going to call for more concrete data. With 3 of the 4 points would be, if we scaled up to 80%, they'd get the highest rating. But the minimal numbers to at least scale up to 60% to get 1 point. Why? Because in a country, we don't think it's viable to be just satisfied with having more than half of population not being covered by this standard of care. That's why we say 60%. And then we're going to have a national health plan to be established by 2026. Why? Unless you have a scale-up plan, you can't implement it. So Yen Millet, I think I saw her earlier. I don't know if she's still there. Yen Millet, can you tell us how HEARTS went from one project in a few provinces to a mass national project in the country? Can you hear me? Well, what happened with HEARTS in Cuba? The first decision was that this not just be pure research project, although we have given that follow-up, but we wanted instead to be a program to improve what already existed in the country as a program to deal with hypertension. So the first decision was that the heads of the Ministry of Public Health would have a different function. We didn't set up a different structure. What we did was improve what already existed and attributed new functions to them. We made these team, the technical hearts team, to be considered experts, and they are supported by those who advise on best practices. That was a fundamental point at the very beginning. Then we included a demonstration site, and then 2 others. And then when we got to 6, because we were working in 5 different provinces and working perfectly well, and we saw that it had great benefits for the citizens. When COVID began, the ministry had already approved that it be implemented in the capital, but COVID arrived, and so the Hearts clinical pathway was used for patients with COVID. In other words, they optimized operations within the health system for a different purpose. Now, once the epidemic was over, we said we should implement this throughout the country as part of the program to control hypertension. So we set up this at the primary healthcare level. We tried to align each one of the decisions to adapt hearts to the country and align it with the primary healthcare policy of the country. So it was a very natural fit. It was easy for advisors to take on this task because they were already doing it for technical purposes. Because from the very beginning, we included not only doctors, but nurses. They have 11,032 healthcare teams working in the country, following a line of work that was part of the national policy. What we've done is apply it at the primary healthcare level. Thank you. I'd like this quality strategy is to scale up hearts. In other words, scale up everything we've mentioned earlier, all 3 strategies, the structure, the process strategy. How do we do that? There's 8 interventions we have to attain to reach scaling up so that at the end of the day, it doesn't stay up in the stratosphere, but it's actually implemented. So this strategy gives rise to the next one. Thank you, Amelia, and congratulations. This is the last strategy. If we have no centers, we're not going to be able to treat anybody. We're not going to be able to identify more people for treatment. So I think one of the problems we have is look at the numbers you are reporting to Hearts. If at the regional level, let me just throw out this thought. At the regional level, we're recording 4.2 million people in treatment. But do you think there are 4.2 million people with high blood pressure in this region? Obviously, no, obviously. So the first question I'm asked myself, if I'm in a country, is where in my country am I reaching, and how many people I am giving them the opportunity to get treatment? How many people am I giving the opportunity to discover they have high blood pressure and they are at risk? So what we are calling this strategy improvement to access to care. It's access, improving access to care. That's the key word. Yes, here what we have to do is remember that people who don't know they have high blood pressure, which we call a diagnostic gap, is a demonstration of how much access the health system provides. If I say 50% of my population has no access to services, that's a very serious problem from the perspective of health equity. So if somebody does not have a diagnosis, it's a marker for lack of access to service. In the world, about 50% of people do not realize they're hypertensive. In Latin America, we're a bit better. The average is 70%. In other words, 3 of every 10 people does not know that they are hypertensive. But there's a lot of disparity. So we have some countries like Canada or Cuba that have more than 80% but then others, Costa Rica, Chile, Barbados, have 70%. But we also have other countries where 30 or 20% know about people who are hypersensitive. In other words, they're leaving 8 or out of every 10 without a diagnosis. So the purpose of our Hearts program is to increase coverage. That is absolutely necessary to increase access, to find out who is hypertensive and provide timely treatment. So our goal here is that at least 80% people of hypertension in the community are diagnosed and receive adequate and continuous pharmacological treatment. And how are we going to measure that? Well, next slide. Well, this is to show you the cascade that I mentioned earlier, all in red, and you'll see your country there. You'll see which one's better or not. All the red is the prevalence of undiagnosed hypertension people, age standardized. And so, as I said, average is a pretty good one. One of the best regions in Pan American Health in the World Health Organization. Our regional average is 70%, and almost all of our countries, 35 or 36, have more than 50% coverage. So this is the reason why we are going to raise our expectations. We're going to raise the quality standards, because if almost all of us have more than 50%, we need to make a bigger effort in screening, in timely detection, and in putting our patients into effective and optimal treatment. Esteban, let's stop here a minute. This is a shock. Is the purpose of this slide is to shock you, to alarm you, pinch yourself and say, am I alive by mere coincidence? Because the blue is saying, and I repeat this, the blue is showing you the levels of prevalence of diagnosis. In the red zone, I'm telling you the access to diagnosis in my region. If you told the politician in your country, well, how's the access for health coverage in my population, and you showed them this slide, what would happen? You shared this slide with them and took it to National Congress and showed them, look, this is those who have access to high blood pressure treatment in the country. They'd be shocked. So that's we have to do. We have to look at things head on, or we're not going to change them. If we can say, if we drop cardiovascular mortality, the biggest contribution we can make to increasing the life expectation in our country and decreasing disabilities, improving and decreasing healthcare expenses, improving quality of life of people. Because another problem we're seeing is life expectancy has increased, but healthy life expectancy has been left behind compared to the general life expectancy in the country. So if you look at this fact and look at where you stand, see where your country stands when you see universal access to health, look at what the access to care is. It's not enough to have a healthcare center where you say, oh, people can go whenever they feel like it. We'll give them medication, we'll provide free. What happens when people don't go? They don't go to the healthcare center. That's why the coverage of the healthcare centers must say, how are we going to increase access? And that's why the strategy is we have to encourage teamwork, because nobody can find this huge number of hypertensives. In the red side, there are already millions of people that are not diagnosed and untreated, working around the streets, and that don't know they have this condition. So let's move on to the next strategy. This strategy is to improve. Well, before 9 was to improve access. Now we're talking about improving the quality of care. Why are we talking about improving quality of care? It's 11. When we talk about quality of care, we're talking about control, as Esteban was saying. The diagnosis, that is the access to finding out if you're hypertensive, and therefore increasing the possibility of receiving treatment, is a proxy from coverage and access to healthcare services. Now, control of blood pressure doesn't just mean dropping or decreasing blood pressure. because as we can see in an emergency room, they give a patient a medicine, they leave him there for a few hours, his blood pressure drops and he goes home. No, we're not talking about that. We're saying that a controlled patient, that is one who's able to reach and maintain his low blood pressure, that means continuous care, guaranteed medication, teamwork, and comprehensive management of their cardiovascular risk so as to increase their life expectancy free of events and a healthy lifespan. That's why our standard for this strategy is to reach the objective of at least 80% of individuals diagnosed with hypertension and undergoing treatment at PHC, implementing Heart's Achievement, and maintained blood pressure levels within the recommended targets. This helps close the equation that we talk about of achieving 80% of access and diagnosis and achieving 80% treatment and achieving 80% of maintenance amongst the treated, controlling their blood pressure. Here, you're going to see a slide that's similar to the preceding one, but here we're no longer looking at access to coverage, but the quality of the care, the control. In dark green, you have the patients who receive treatment and are properly controlled. And then in lighter green, you have those patients that do not have quality health care. And that's how it has to be looked at. Now, here, we see only 2 countries of 36 in the region have figures above the 70%, and above the 80%, only Canada reaches that standard. The average for the region is at about 60%. And here I'd like to appeal to countries to improve the quality of their records and the data analysis. Why? Because the average for the region is above 60%, and yet we get reports from health centers that have control rates of less than 30 or 25% coverage. So, or treatment. If we didn't do anything, statistically speaking, we would have 60% of our patients that have been identified under treatment. But how can therefore you have countries that report only 20 or 25% control? In other words, we need information, an information system, but we also need quality care that does emphasize data, because if we have the wrong data, we're not going to be able to move in the right direction. And there's
Just to
I think we can, let's look at this a bit, because I know that right now when we present the next slide, where people are going to say, nobody's asking for 60%. We already have 60% in the region. But the problem is, look at the numbers there. 4 of 36 countries exceed 60%. So there are 4 of 36 that are on that path, but there's 2 of 36 that exceed 70%. But most, 19 of 36, have more than 50% control. So we're not going to lower the control level at the national level to please somebody else. Remember the Society of Mutual Praise. We're not going to lower a standard for people to qualify and be able to join the Olympics. If the problem is the data, it's time for you to think about this. Maybe your denominators are wrong. Well, if they're wrong, then you have to fix them, because otherwise it's the same thing as going with you don't know with the gasoline gauge in your car, you know what kind of pressure you have in your tires, or if you don't know how airplane how to drive a plane if you don't have a dashboard. And so you can't use that as an excuse. You need to have the data. And maybe you must realize that there's problems with the data. Now, there's no doubt that there's a problem with access. There's no doubt there's a problem with quality, because if we don't do what we have to do, and we're having a great deal of work trying to move forward, then how can we not realize that we have to focus on data? We have to improve our data. The verifiable indicators here have a minimum cutoff level of 50%, but what we're hoping that most countries will be able to implement this very modest goal of having 50% of their patients improve the quality of care and having their patients under treatment. But the aspiration is to reach 80%. Why? Going back to this 80%, 80%, 80% means it would give us more than 50% of control at the population level. And as I said in the first slide, if we want to have impact on mortality and morbidity and the burden of disease and a significant level in the country, we then have to increase the level of control and treatment of hypertension. Let me say about another thing. Remember, I've talked about this often. Go back to strategy 10, the indicator of how to improve access to care. Let's assume that you do have 50% coverage in your country, or 50% coverage at your health center, the one you're evaluating. Now, if you have a calculator there, I'm sure you have a phone with you. Put down 0.50. I'm going to give you a test. Assume you have 0.50%. Maybe you have 0.60%, maybe 0.70%, whatever. But let's put just 0.50% coverage. Okay, let's now go to the slide after strategy 11 and keep that 0.50 on your computer. And now let's assume you have quality of 0.50%. You've only treated 50%, which is what most countries here are doing. So multiply 0.50 by 0.50 and see what you get. What did you get?
So what is it you got? 0.25. And you know what that means? That you've got 0.25% of population control. That means that you've only got 1 out of every 4 hypertensive patients controlled in your country. If you have a 50% control and a 50% level, then you have that. Now, these figures that we're putting here of 80 and 80, it's part of the mutual praise society, because 0.8 by 0.8 results in 0.64. True or false? 0.64, right? Now, of course, that is far better. And if we had a 25%, if we were able to increase the 25% control to 0.64, we'd have a reduction of 3% mortality per 100,000. That is the calculation that you need to present to your authorities if you want this to have practical meaning. And 5 to 6 times in the case of events. It depends on the mortality in your country. There are countries that they don't have high quality of hospital service or pre-hospital service for acute services. They don't have a good care system for cardiac infarctus. So that's what we're talking about. The impact can be massive here through what we're doing. Summarizing, and next one. We have seen that to improve the quality of care, we needed to have this map in mind. This is the exercise that we hope you will perform. You needed to define your 11 strategies and do so very clearly. Define that there is a minimum structure to be strengthened. Define that there are process strategies that need to be reinforced, that all are focused on the primary healthcare center in order to achieve these program results. Scale up the program to most primary healthcare centers and networks, improve the level of access to care, and improve the levels of quality of care. The level of access to care is measured through program coverage, and the quality of care is measured at the level of population control. So how can we be sure that the changes implemented are truly representative of improvement? Next one, next slide. And here we can see the heart monitoring and evaluation system. Once again, Matthias said this, not me, and Matthias is an authority. Without data, there's no program. So let me ask my colleagues, Elibardo and Mariana, Esteban, Libardo, and Mariana. Go ahead, please. Thank you, Pedro. As Matthias and Pedro have pointed out, it is important to gather all this information to have a repository. But before that, I want to talk a little bit about how we're doing it and how we want to do it as we move forward with the new standards. So let me give the floor to Mariana to explain the framework to us. Thank you, Libardo. As you all know, HEARTS has this evaluation framework that is focused on the health center. You're all familiar with published papers. And in addition to the maturity index and the heart's development. Mariana, please repeat that. It's centered in the primary healthcare center. That's something that we have to repeat it time and time again. The PHC is the heart motor. It is where the difference can be achieved. It's where we bake the bread. At other levels, then you'll just measure how many loaves of bread you've baked. But the bread is baked at the primary healthcare center. It has a defined population and territory to cover. They are responsible for delivering service and healthcare to that population. I apologize for interrupting you, Mariana, but I wanted us to truly focus on the PHCs. Yes, indeed. If we want to make these PHCs operational, this is an opportunity that is highly significant to do so. If we meet what is mentioned here, if our PHCs, they have their population for which they're responsible, their territory, and each unit, depending on how each country is organized, they have to have the capacity to know about their performance, and to know at what level they have achieved in implementation, their maturity. That's how they can achieve improvement. Now, when you're looking at the country or territory level, you also need to have this information for the national strategies. And this is the framework proposed by HEARTS on the one hand, at the level of the health center, for them, for you, and for everyone to have access to the indices for implementation and performance. And in your case, that you'll be able to measure the 11 strategies that the HEARTS policy quality will be focused on. So this is a framework, but how do I do it? How can I turn this into something operational? So our fantastic engineer, Libardo, translated all of this into an information system, a computer system. Libardo, please explain this to us. Thank you, Mariana. You have you have heard about DHIS too. The system was built, the District Health Information Software. It's an open code platform most used with a health management system. It's the most used throughout the world. In many cases, it ensures interoperability with most existing electronic case history as used in the countries of the Americas. As was mentioned, and under the premise that without data, there's no progress, without data, there's no program. So our system is one of the fundamental pillars. It is central to the new HEART strategy. Our system allows each primary healthcare center to have an analytical report in real time, and all the access to all the dashboards to assess everything having to do with the maturity and performance of the program. The system, as we've always said, is based on measurable objectives and standardized indicators to not only learn about the performance of our program, but compare it with other healthcare facilities. It seeks to standardize and empower the establishments and facilitate the change of paradigm in managing cardiovascular disease. The focus obviously is placed on the PHC, and it makes it possible for ministries or regional institutions to see where improvements are needed. In the framework of the strategies that we're discussing, the HEART strategies, we need a repository, a central repository to gather all this information And this will be provided by each country. And as Mariana pointed out, we have two integrated HARTS sources, and they're both integrated in the DHIS software. One is based on the health centers, as I just mentioned, it's broadly known, and gives real-time dashboards and allows us to monitor maturity and performance indices. And the new one that we're going to explain in greater detail today is a national source of data that is based on the quality and evaluation. And the results are reflected in our very well-known heat map. These tools will give us a general integral vision in real time of progress in the implementation of HARTS. Now, this is important to provide a context as to how we're gathering information. We have a timeline based on the twice-a-year periodicity. We have our previously known survey. This will be placed and centralized in DHIS2. I'm now going to switch on the platform and I'm give you a rapid tour of this new tool where countries not only will upload their data, but furthermore, they'll be able to update and see all of these updates in real time. Pedro interrupts to say, we want to reflect this right from the beginning. So the systematic evaluation data for HARTS will be simplified. It is being simplified. There are fewer questions, fewer evaluation indicators. And instead of using the Excel table or the survey that we did with the Software Monkey, what we're doing, Survey Monkey, what we're doing is facilitating the process to gather the information. Am I correct in what I just said? Yes, not only facilitate the processes, Libardo, but also have the historical. And this is important because as national entities will be able to see the timeline and the improvement of each indicator over time. Pedro, what does it mean to have a historical? Please explain, Libardo. Well, every time the country updates the timeline, I'll be able to see and compare with previous or earlier times. And this is very important in order to for the national entities to be able to see which indicators have show improvement and which indicators needed to be improved upon. To give additional context, I know you're all familiar with the semi-annual report, our famous Excel. The idea here again is to focus all of this into the DHIS2. Countries who are implementing the system will not need to fill this report any longer because they have the information with different timeframes, with the added advantage that each health center can visualize it whenever they want in real time. Not only nationally, but even the health centers will see the progress of implementation. Pedro interrupts again. As I don't really understand this topic thoroughly, I want you to explain it to me better. So right now we're sending the Excel to the countries, and the countries have been working with these Excels for several years and submitting them annually. Now we're no longer going to work with those Excels. Now we're going to have a system where you can upload the data that is called DHIS2 with the advantage that you pointed out that I can have the information and I can look at it in real time. And I'm also going to have a historical record of all the data. If I'm in El Salvador, for instance, I'm at a health center, as I have DHIS2 aligned with the information system of my country, I don't have to do anything new because that is actually what is happening in El Salvador today. Did I understand correctly? Libardo, yes, absolutely. I'm saying that the countries that are already implementing DHIS2 at the primary health cares have no longer the need to fill our Excel spreadsheet. The idea, and I want to be clear with this message, we're not asking for all the indicators, just we ask for the country to complete those that they are actually implementing They'll see the process. They'll know where they need to improve, where action is needed, where we need a clinical history. So the message is not that 100% of the indicators need to be completed. That would be the final goal. But with this tool, we'll be able to visualize the processes, and we ask that you start using it, Pedro. So Libardo, let me see if I understood you correctly. There are some systems that if I don't complete question 1, I can't move on to question 2. And if I don't complete that, I can't go to 3. If there are 10 items and I can only report on 3, I just fill those 3. So there will be a vacuum for 7 areas. In Hearts, we're also having an economy of indicators that are essential for a program. And that's what we're aiming for. So there are many more indicators, yes, obviously, but here what we're talking about, the indicators that are essential to manage a program. If my country has 10 indicators and out of these 10, they only have some of them completed. In a plane, you'll know if there's turbulence, the height, the altitude, lack of fuel, or the wind power, battery, etc. Now, if a country has to report on 10, but they only know about the speed, but they don't know if they have the fuel necessary, then fuel is going to dry up at some point. But we're not going to limit them. Is that what we're saying? Correct, Pedro. Both for indicators and for the frequency. There is an ideal, and it's to have it. There is a periodicity for each module. Perhaps the country can report every 6 months on the information, but they will have semi-annual information that way. But in some indicators, they will have monthly information. There is no restriction as to this. There is an ideal goal, and that's what we want to achieve, to see the existing gap in each country, and that way close the gap as much as possible. Pedro, so if I'm at my health center and I upload my data, I'm going to see a dashboard looking at the data for my own center. If I work at the provincial or district level or state level or country level, there again, I'll be able to see how the health centers under my jurisdiction, to see what progress they are making to implement the program. Is that correct, Libardo? Libardo, yes, absolutely. Depends on the user level and the profile. They'll be able to visualize each of these areas, focusing on the health centers.
And to go to the context of what we are discussing in the survey, we also have what we call the installation part. Most of you are familiar with our scaling up cell. It was an Excel sheet. Now this will be included under DHIS2 with the same purpose, that to make sure that all this information, every time a country sees a change, they can update it and it's reflected in that sheet. This gives us an updated repository of all this information instead of the 6-month reports we required before. Stop here a minute. Let me see if I understood correctly. So let's say I'm a country that has 100 centers implementing Hearts by June of 2024. That's the last report I have. Right. Now, I don't need another report until the end of December 2024. However, if I'm using this system in those intermediate months, I could update the number of centers that implement information. If I went from 100 to 120, I could record it. And when I go from 120 to 160, I could. And if I go from 160 to 300, I could also record it without having to wait for the 6 months report. Is that correct? Did I understand it? Yes. Yes. Perfect. That's the purpose. That also means, therefore, that if my boss, the minister, the politicians, whoever, want to know how the implementation of Hearts is proceeding in my country, at any point in time, I could show him the data of how the implementation is taking place in my country. Yes, not just that, but download the aggregate information and give a report that gives a quick view of where the implementation stands in each one of our centers. Okay, go ahead. Let me give the floor now to Mariana, who will explain a bit how this fits into the evaluation standards. As Nora said from El Salvador, it's important to see what the source of all this data is. and how you structure the tool, the heat map, which is the result you see at the end. And I'm going to show you an example in a minute, the heat map. But it's important for you to understand what are the sources used to evaluate each one of the indicators that were presented to you in the different strategies. Now, Libardo is going to give you a tour of the platform so that you can see a user that you choose at a country. That's a focal point you choose, could be one or two, whoever you choose, who has the capacity to enter the data. The country will decide who will do that. The country will also determine who can look at them, who can use them. That is up to the country. But we will send you your users and your passwords. And if somebody has not yet received it, or the user has been changed, the user to whom you want to give the permission to enter, you can contact me or Eduardo, and that way you'll have the list of users and access to the platform that Eduardo is going to walk us through now. Eduardo, go ahead. Okay, so you can see my screen. Can you see the screen? Yes, yes, we can. Okay, as Mariana said, we did a compilation of our focal points in each one of the countries. It must be clear that these are profiles that have already been established, but if you need to change it by mail, please let us know, and we will create these profiles at the national level. Today, I'm only going to focus on the survey model and the scale-up matrix at DHIS2. So each one of you can enter your sign in with your name, username, and password. And here you can see the well-known dashboard. And I go to hypertension, not high risk, and you can see the dashboard you have, we have created. We have not high risk hypertensive, or we have high risk hypertensive diabetes with diabetes, implementation maturity, performance, and our well-known heat map. This tour is for those nationals. If the country is implementing DHIS2, the health centers, all of them have access to this information. However, the new app, the new way of entering data that we want to explain to you is done at the country level. So here on the left, you see the all the countries that are implementing the strategy. And under each one of the countries, the person will be able to enter and select what we call our new heat map. And there you will select the period. As I said earlier, there's a 6-month frequency. So I will pick the period for which I will enter information. And here you can observe the standards for the questions that are reflected in the explanation given by my colleagues. So each one of these has a simple question that is added, and most have multiple selection, multiple choice. And for most, you can update a file that would submit the evidence for the question. So we, as Pedro said, we have decreased the number of questions. We only have 11 now, and it provides a much more general and specific context for each one of the strategies. Let's look here at the top for each one of the strategies. There you have, and you can then update the information for that strategy. And here I have the period in which that strategy will be updated. Each time I want to make a change, I can select it and update it in real time, so that the data are updated in real time in each one of our countries. Libardo, one of the things that I think is going to change is the following. For instance, when we ended the first quarter, we'd send an email to countries, the first quarter is over, first semester is over, we're going to send you information on this, and this is the Excel sheet, this is scale up sheet, did about 30 different tools, and we're not going to do that. None of that. Now, on 30 days after the close of the semester, will see the information each country has updated, which means that it'll avoid problems for us and for you. We don't have to get behind. We don't have to bother you. It's the information that's available, and countries can update it as it occurs. There's some information that doesn't change. The only information that changes is the miracle, how many patients receive treatment, etc. And you can update that every day or whenever you want. And as El Salvador said, I don't have to continue asking for it because the information is updated on a regular basis. The difference with this and the dashboards, and I must insist, this is not a dashboard. The difference with this and a clinical history is that Hearts is not proposing to you, you have to have this kind of clinical history. All we're saying is, here are some variables that help you measure the quality of care for these people. Include these as the variables in your usual system. Now we have a program evaluation group to evaluate the strategy for implementing HEART. And you, as you update the data, you'll be able to see what's going on. I know that in the next few days, you're going to be able to play with this. You don't have to wait till the end of the year to update the data. Oh, and the other thing that this system provides, listen to this, is that if you don't report from last semester, you're going to be using the exact data from last semester. What's a disadvantage? Well, if you did increase a number of centers or number of patients treated, or you did see an increase in the system, you're not going to have that data. Now, let's do something, because I think this is very important. I think the first part of this presentation was only conceptual. Maybe now we need is to organize another session. Actually, for those countries who think we should have another session, please write it down in the chat. We could organize it by group of countries to teach you exactly how you work on this. And we'll now have a group of volunteers that'll help us set up that system. Eduardo, now what we're saying is, when the 2024 system ends, the reporting system we're going to use now is this one, not the old one we had. This will allow us to have more information. And somebody was going to say, oh, this is going to affect the scores of the countries from past evaluations. Doesn't matter. That's not a big problem. The problem is that this new system with the new indicators once again will serve as the baseline for 2025 and 26, the next 2 years. In other words, if you have this kind of information and it's updated, imagine what it'd be like to share this information with the governance group in your country, your managers, the minister of health, or the politicians of the country. This, as you know, DHIS2 with these reports for the centers will allow us to map it and tell where the center is located and verify the level of implementation and development for each one of the centers we have. So I'm going to stop here, because this is a big step we're taking to make things easier and at the same time strengthen the capacity of countries and the health centers. You have the floor again. Well, okay, let's put this in the proper context. We have all the different sources of data. Specifically, these are only at the national level. So we have the data sources that come from what we called before the survey, which was the 6-month report and the scale up matrix. So what's the purpose of this? That we end up with a heat map, which is the final product. It'll come from DHIS2. It'll be updated, and the national centers will be able to have this information. Mariana, can you explain a bit more about how this strategy will work? Thank you, Eduardo. Next slide, please. As you said, with this evaluation of 2024-2, we will have a baseline where all the countries will be standardized and will serve as a tool for undertaking continuous improvement at this level. Here you have the visual example of how your data would appear. Currently, we're only using the past indicators, not the new ones that are being proposed in this strategy. But you're going to see this in DHIS2. And you, as you change your parameters, you'll be seeing changes on the screen. So you're going to have this map that can tell you what area needs more attention, more focus. And as the team said, this helps us in our planning process. What we are proposing, as you do in the health centers, a cycle for continuous quality improvement with a frequency of every 6 months. So every 6 months, we propose that you update the data in the monitoring and evaluation system. Next slide. Next. And with this, next, you will have the improvement cycles beginning with 2024, 225, 1, and then 2025, 2 at the end of the year, and so on and so forth until we reach a level of maturity of implementation and control in all our health centers. That would be wonderful. So this is the proposal that we are making. And here I leave you with Dr. Ordóñez and want to remind you as to why we are doing all of this. What is Heart's mission and what are we all working so hard on? Well, I think that the team of Eduardo and Mariana have created a very graphic operative system. And I see in the chat there's questions. Panama is asking for a presentation of the new version of DHIS2 at the next date. And they are asking Eduardo to explain to him. So, Eduardo, you have a first country now that is asking for a meeting with them. We'll do that. But this, what I can say is that this is just going to make it much easier for you, a lot less work, more comfortable. It doesn't make your work, it doesn't solve your work. The access of people is done by diagnosing them and starting their treatment and providing good care to them. But the data complement that, as I explained earlier. So if we want to get to 80% of detection, 8% of treatment, we will have a discrete number of 50% control. And in this society of mutual praise, we might be satisfied with 50% control and let the other 50% be covered by others. But we're not saying that. We want more than 50%. And it means that we have to duplicate our efforts. Yes, you're correct. Double our effort. So I ask that those of you who want more information on this session actually has been recorded and we'll share the recording with you. But I thank the team very much for the work they've done in presenting this today. I'd like to thank the countries who participated and those who didn't participate orally. I would have loved to have heard somebody from the Caribbean, but when I asked for volunteers from the Caribbean, I didn't see any, but I'd love to hear from the Caribbean more, because as we're coming to the end of the year, 2024 is about to close. What we want you to do is review what you've done so far. I think that visual things help enormously. I don't know if you did the exercise. Do you know how many points your country have? As we did this, were you writing down the number of points for your country? The purpose is not to depress you, but rather tell you what you need to do to fix, how you're going to improve. And now I think we have a dashboard where you will be able to visualize what you're doing. And I think having something visual helps enormously. It doesn't replace, but it does help significantly in understanding what we're doing. So I invite you, and we said this at the very beginning, the countries that first implemented Hearts know that the stronger our community is, the better we'll be able to do this. The more champions we have who teach us how to do this and show us that it can be done, the better the standards we'll have. So for those countries that participated today and those who didn't participate as well, we're very grateful for your time. We hope that this has been an opportunity for you to share. Let me see if I can see somebody who might like to ask a question of Natalia Besantine. Is she not there anymore, Natalia? Yes, she's there. She said goodbye. She had to leave. Maybe Santiago? Well, I was wanting to see if there were some people who could give us a final summary or comment on something specifically about what we have here. But if not, do we have Patrice still? Patrice Lawrence in Jamaica, but is covering Bermuda and some other countries around Jamaica. Patricia, are you there, Patricia? Patricia? No, seems she's not. And we hadn't agreed in advance of who should speak, so I hadn't made a list of who could speak, but I did want to say that we're very happy that all of you have joined us, and we hope you've learned and benefit from this. We have to identify the countries that did not appear so that we can look at this topic with them, and we hope we'll be able to move forward on this. One of the champions of this is Matias Viector. Matias, can I ask you to summarize the conclusions of this meeting? Matias? Thank you. You're asking too much to summarize and conclude this meeting, but I was putting it in the chat. We are moving forward in gigantic steps. We're very pleased, and the presentations were very clear. I think, and I put it in the chat, that we are not going to take a step backward. We're going to be moving forward, and the team needs to continue meeting to help strengthen the progress made by each country in helping overcome the difficulties each country has had. Because by helping them, we're helping ourselves. From El Salvador, I think we need to know how to make a policy decision. One other thing we learned is that some countries had encountered difficulties, and what we did was correct the problem and to avoid those difficulties and learn from the experiences of other country to improve one's own. In fact, within our own country, we've learned from the experience of other health centers to move forward. Congratulations. I conclude with this, and thank you for the technical assistance you've provided us. You never leave us alone. And thank you for responding to all the requests we made and problems we encounter. Good news for El Salvador is that we now have included Metolopin in our results, which was what was missing. And it is in our internal guidelines so that now a nurse can provide treatment, because that was one of the obstacles we had. But we've asked for, from the strategic fund, a specific amount of telmisartan and amlodipine, and we will see what response they give us. Again, thank you very much for your support. Thank you, Matias. I'm so happy you were the one that closed the session. As I said earlier, I'd like to get your thoughts. If you think we need to have another complete session on data and how we can use the data to build a system, we can do that. But we're going to await your suggestions, comments. So put that in your chat. Panama has already asked, but if somebody else feels they need to have a session with Ricardo, Mariana, or a member of the team, we would be happy to do so. Have an excellent day, and thank you very much. And we'll see you at the next version of Heart in the Americas. We hope 2025 is a better year. If we don't see you before the end of the year, have a wonderful Christmas, a Happy New Year, and let's close 2025 as should be done. Thank you. Goodbye.